Welcome to this webinar on acute coronary syndromes in the times of COVID-19. And this webinar is about how to get your unit ready. I'm Susanna Price. I'm president of the Acute Cardiovascular Care Association, and I'm speaking to you today from London. So the first question that we're going to address here is, why on earth are we even thinking about patients with acute coronary syndromes in this extraordinary event where we have this pandemic that's overtaking countries one after the other? And I think it's really important to remember our patients that aren't coming in with COVID-19, in particular where they have life-threatening and particularly easily treatable diseases. And absolutely this is represented by the patients with acute coronary syndromes. These patients can have evidence-based interventions. They need them in a time-critical manner, and this will potentially save their lives. But working in this environment, you have to remember that no matter what you think is going to happen, the resources that you would usually use will be significantly impacted and things will look very different. Pathways within your hospital that normally work seamlessly will be profoundly different, and even pathways of how to get the patient into the hospital will look profoundly different. Even more important than that, though, is to consider your staff, your greatest resource, and also the patient, the most precious person in front of you. Your staff, your patients may be sick or have been sick. They may have been quarantined or been in social isolation, and they may have been bereaved by the very disease that they may have or that they may be reading about every night on the news. They will be frightened, absolutely, certainly, and as time goes on, they will get increasingly exhausted. So you need to be aware of this, and you need to be aware of the human factors associated. And in this context, you're then taking your staff, many times redeploying them and developing new team working structures. So in order to be able to save lives, which is so important with our acute coronary syndrome patients and any other patient with an acute disease which is potentially treatable, we must plan and prepare for them as well for the patients who have COVID-19. So the next question that I've addressed, which I think is probably the most important, because the staff are our most important asset here, is we're very used to protecting our patients. We're very used in the cath lab to protecting ourselves against radiation, but we don't really normally think about protecting ourselves more than that, but we really do need to right now. The first duty of any employer is to protect their workforce, and I think never has that been more important and more evident than during this emerging pandemic. And personal protective equipment, or PPE, is absolutely vital, and we're hearing across the globe that this is a big challenge. You need to prepare and order early. Whatever volume you think you might need, you should double it. You need to make sure you have more than one supply chain because it may not be reliable. And you need to protect your equipment. You need to lock it down, you need to keep it safe, and you need to make sure it is always available for your staff. Train your staff in putting this equipment on, donning, and train your staff in taking this equipment off, which is the more dangerous phase, doffing, which is taking off, and train them again and again, and do it appropriately with buddy systems, with people who are great at training. Remember to isolate your non-essential staff. Send them home if you don't need them. Develop new ways of working with a remote teamwork. And remember that you're in it for the long run. This is not a sprint. What we've learned from China and Italy is you're in for a marathon. Think about your staff's well-being. Think about where are they going to get food if the supermarkets are all empty. Think about giving them refreshment breaks. Think about mindfulness. Think about team debriefing. And use the resources around you to do this for your staff. It is so, so important. There is no place and no room for heroics in this. This is all about keeping your staff and your patients safe, minimizing harm. It is not the time to enhance your career or thinking that you're going to be the big hero. This is about teamwork. And I cannot overemphasize the importance of washing your hands. So that's how to protect yourself in this current status. Next, we're going to think a little bit about the patient and how do we actually get them into the cath lab when you've got a hospital that looks and feels completely different. So if your patient is COVID-19 positive or suspected positive, you need to develop standard operating procedures and drills, whether it's bringing the patient in from the ambulance or in from your intensive care unit, your coronary care unit, or wherever you may find them in the hospital. You need to have a trained, dedicated transportation team. And I've just shown you here an example of what that training would entail and what you need to think about. So in my institution, if we're taking a patient to the cath lab, to the operating theatre, or to the CT scanner, we alert our security and the destination teams 30 minutes before. We make sure that these corridors are cleared. We make sure the staff are safe, and we walk through without touching anything, with all doors held open for us till we arrive at our destination, which is then locked down. And we have what we call a spills officer that makes sure that we have not contaminated ourselves or any of the environment as we're going, and they clean as we go. When we've finished our procedure in the cath lab, of course, you have to give time for cleaning to make sure that it's safe to use for the next patient. In this transition and getting there, you need to minimize aerosolization. And if there's any risk that your patient may need intubation and ventilating, do it before you go using your dedicated intubation and ventilation team. And remember that this is going to take more time than you're used to. You'll be thinking that you need to get to the cath lab fast, you need to intervene fast, but your team must be kept safe beforehand, because if you don't do that, you will lose your team and you won't be able to save many subsequent patients. So we've been in the cath lab, and now we're going to come out of the cath lab. And there are certain things that are really key when you're thinking of where you're going to go next. You need to know your destination. So if you've got cohorts of patients around the hospital, is this patient COVID-19 positive or suspected or negative? And you need to make sure they're going to the appropriate area of the hospital with the appropriate transportation that you need. And if the patient is positive and you've come from, for example, your ICCU, you use your standard operating procedure in reverse to get the patient back. Remember to think about the patient and the environment that they're going to go back to. Remember that the primary care practitioners will be overrun. Think about how your patient is going to get their medications when potentially they won't even be allowed to leave home, or they may be elderly or not particularly able to get to the pharmacy to pick up these new drugs that will be unfamiliar, and they may be frightened about the side effects they may get. Telephone follow-up is vital, and self-rehab advice, although difficult when patients are living potentially in social isolation, needs to be thought about. And remember also that your patient will have turned on the news every evening and heard that patients with cardiovascular disease are at particular high risk of dying if they develop COVID. So the fact that they now potentially have a new diagnosis of cardiovascular disease, whether they're already COVID-19 positive or whether they're thinking that they may get it, they will be very frightened, and you need to give them appropriate and measured reassurance and advice as to how to protect themselves. Next, we have to consider, and we don't frequently have to worry about this, what do we do about respiratory failure? So currently, general recommendations, if a patient develops respiratory failure, you have to regard them as COVID-19 positive unless proven otherwise. And this relates to patients with heart failure and breathlessness if they come in as an acute admission, because there have been a number of surprises when the patient was thought to have a different diagnosis and they turned out to have COVID-19 as the primary diagnosis causing the dyspnea or a concomitant incidental finding. And I divide these into two groups of patients. So the first are the ones that are not intubated and ventilated. So they may be breathless and they may have CPAP, or they may just be breathless and having nasal oxygen. And these patients absolutely must be risk stratified by people who really know what they're doing, by your dedicated intubation and ventilation team. They risk stratify, and if there is a risk that the patient will deteriorate during the next few hours or minutes that you're going to be there in the lab, you need to intubate and ventilate before you transport the patient, so do it early. And remember that if your patient is not intubated and ventilated, you need to look at the current guidance for cardiopulmonary resuscitation and the ALS algorithm in the context of COVID-19. And the first rule always applies: make sure you're safe before you approach the patient. Is it safe to approach? And in this case, it means making sure you have PPE donned. Don't put yourself at risk of having a disease that may kill you because you didn't do that first. In patients who are intubated and ventilated, have in your mind, if the patient does have an arrest, that there may be a non-cardiac cause, and your anaesthetist or your intensivist who's with you, with their team, will prompt you on that. But don't get fixated on just cardiac causes. Think about your strategy if the patient is in the prone position, so the patient is face down being ventilated. We know patients who are COVID-19 positive respond very well to proning, particularly in the early acute phases of the disease. So what are you going to do to manage this patient? And you need to have a strategy for that. If it's possible, it is best to put the patient back in the supine position and do your procedure as fast as you can, and then turn the patient back prone after you finish the procedure. Consider also what you're going to do if you have to resuscitate a patient and commence your ALS algorithm if they are in the prone position or face down. And the recommendation is you do the ALS exactly as you would do. Don't turn the patient back on their back, leave them prone, and do your chest compressions from the back. The final area I really want to discuss is preparation. How do you prepare your teams? How do you train your teams? And this is absolutely vital if you've even got a fighting chance of having a good functioning working team and saving lives. So you're going to have to move into a different way of working. You're going to have to learn lessons from disaster medicine and trauma medicine, and you're going to have to establish a command control structure with regular sit rep, which is situation reports, at least 3 times a day. So you know what's going on in your hospital and you know what's going on with your teams. Establish education and training streams as an absolute priority as early as you possibly can. You cannot start this early or too early. And remember that your team working will be very different. So rather than having teams that are responsible for globally for the individual patient, you will have teams that are being redeployed to maximize their skills. So you may have teams for intubation and ventilation, teams for proning, teams for lines, and that's where interventional cardiology comes into its own, so arterial and venous access. So your training will be related primarily to maximizing using those skills within this new working environment, and thinking about how you're going to support staff who are redeployed to an area which they may not be familiar. Train as early as possible. Take staff out of their routine lists and get them trained absolutely as fast as you can. Think about team building and human factors. It can be a very positive experience to get these teams together and learning new skills together, to have great trainers, utilize again the resources you have around you. And please, please, PPE, so keeping your team safe, is absolutely your first and most important priority. Please keep your team safe. So my main messages, I would say, are these. So the first is to consider where you are as a structure and as a network. So that is critical care networks, cardiology networks, PCI networks, ambulance networks. You may need to form new alliances. You may need to redistribute work, and you will need friends right across the network. Plan for the worst and very much hope for the best, but please plan for the worst. It's going to be difficult. And if you wait until these patients are really appearing in your hospitals and your area, your network, your critical care units, and you only start preparing then and planning and training then, it is too late. So get on and do it early. I would also say our mantra in our hospital now is stay safe, stay well, wash your hands. There's good evidence from contagion modeling that we know this has got a lipid outer core, and that soap and water with hot water washing destroys this. You should be using soap and water hand washing with the evidence that there is supporting 5 times a day significantly reduces the risk of transmission. So please wash your hands, soap and water. And finally, I would leave you with this. This has been known by the military for many, many years. And no plan that you will have will definitely work. You may find that the moment this tsunami of patients appears in your hospital, that you're going to have to change your plans. So please be flexible and be prepared to adapt within your command control structure. And finally, I would leave you with this. Please, please stay safe, stay well, and wash your hands. Thank you.